Macular hole surgery managed by relaxing incision of hole margins in patients with FFP.
और वीडियो कैसे चलेगी?
Use. Thank you, doctor. He's going to start. He has to go to the airport, so we are going to start with his presentation. Thank you, doctor.
I am Dr. Faisal. The topic of my presentation in this surgical seminar is surgical management of recurrent and persistent macular hole. No financial support or conflict of interest. What is macular hole? A full thickness macular hole is defined as a full thickness break in the retina which caused decrease in the vision. This is macular hole. The annual incidence is reported to be 4 to 8.69 eyes per 1 lakh population per year. The primary closure rate of macular hole is greater than 90% with current methods with vitrectomy and ILM peeling and gas tamponade. After closure, macular holes may reopen in 3.3 to 9.2% of the cases. In one study by Valti Piras, the reoperation on reopened macular holes resulted in anatomic closure in 100% of the 21 cases. What are the risk factors for primary macular hole surgery failure? Number one is persistent vitreal and epiretinal traction. Second, chronicity of the hole, inadequate gas tamponade, large aperture diameter, and high myopia. Surgical techniques of recurrent and persistent macular hole are, which are doing right now, are vitrectomy with ILM peel, internal limiting membrane flap, which has been discussed in previous session, lens capsule transplantation, autologous retinal transplant, amniotic membrane transplant, and autologous platelet concentrates. Now, internal limiting membrane peeling. The Kelly and Wendell reported the first series of the patients which undergo successful vitreous surgery for idiopathic macular hole. Eckhart et al. Introduced ILM peeling in 1997. This is the method by which ILM peeling was done. Internal limiting membrane flap. Michalski et al. Described the use of inverted flap for macular hole closure in recurrent macular hole. Lens capsule transplant was introduced by Chen and Yang in 2016, and the closure rate was 96%. Autologous retinal transplant. In 2016, Grewal and Mahmood introduced the use of autologous full-thickness retinal free flap for closure of refractory myopic macular holes. And in multi-center case series of 41 eyes with macular hole refractory to prior vitrectomy with ILM peeling, 87% achieved anatomic hole closure after autologous retinal transplant. Subretinal bleb. Meyer et al. Achieved closure rate of 85% in case series of 41 eyes with large macular hole. This was performed by hydrating the margins of the macular hole. Amniotic membrane transplant. Rizzo et al. First reported the use of human amniotic membrane and for macular hole closure in 2019. Retinal relaxing incisions. Charles et al. Presented a technique involved the creation of full thickness arcuate retinotomy temporal to macular hole. By using this technique, 5 of those eyes have successful macular hole closure and 3 demonstrated an improvement in the visual acuity. Autologous platelet concentrate are believed to contain growth factor and cytokines, and Godric et al. Decided to test the effect of autologous platelet, and they found a statistically significant difference in macular hole closure, that is 95%. This is my case in which a 60-year-old female patient who was only eyed presented with decrease in the vision in the left eye. On examination, right eye was counting finger and left eye was 3/60. There was bullous keratopathy in the right eye, left eye was pseudophakic, and there was full thickness grade 4 macular hole. This is the video, pre-op video of the patient. This is approximately 1478 microns basal diameter, and this is the color map. The first surgery was performed with ILM peeling, and C3F8 gas was injected, and post-op visual acuity was improved up to 6/60. This is the first post-op OCT. Now, after the first surgery, the size of the macular hole will decrease from 1400 to 1231 microns. Then we decided to perform the second surgery. And in this surgery, I used to do the relaxing incision at the macular hole margins, and I also used platelet-rich plasma in this case. And after the second surgery, post-op visual acuity improved after 1 month is 636. This is the video in which I perform vitrectomy. This is the second surgery. I did the air fluid exchange. After that, I used the dye to stain the ILM. And you see, there was no ILM at the fovea and macula, which was peeled previously. So I decided to do the relaxing incisions at the margins of the retina with scissor. I did very small relaxing incisions at the inferior and superior margin. And this is at the superior edge. After that, we perform the air fluid exchange. And after performing the air fluid exchange, this is the first follow-up of this patient. You see, macular hole is closed successfully. This is the color map. This is the second follow-up. Macular hole is closed, and the vision, fortunately, alhamdulillah, improved up to 6/18 with correction of -1.75. I don't know why it happens, but I give all the evidence and OCT, and my patient is happy. This is a color map. Thank you so much.
Thank you, doctor. Any questions to the doctor, please?
Yes, sir.
There's a microphone if you want to ask.
No, sir. Sir, left eye. Any question? 618 सर और ये बस आने से पहले मैंने किया है इसका and she is very happy.
Thank you for sharing this technique. Just a question on tamponade. So were all your patients pseudo-fake?
Okay, our next speaker.
All these patients pseudo-fakes or fake?
Yes. Which one?
These were all faking patients or
Pseudo-faking. Pseudo-faking. Right one is AC IUL and left one PC IUL. Patient age was 60 years. Has been operated for cataract surgery.
Did you use the autologous platelets you mentioned?
Yes, I used both. I did the relaxing retinotomy and autologous serum as well.
Because there are two variables.
Yes.
How can we say whether it was the relaxing retinotomy that worked or platelets or perhaps just a tamponade?
Yes. But I use both techniques because she was only eyed. I cannot take the risk. That's why I give a full opportunity to the patient and my patient gained the vision successfully.
Thank you. Very good presentation. Now Dr. Mansar Saed is going to present ILM graft for persistent macular hole surgery.
Hello everyone. I was on this podium a couple of days ago and I was talking about Denzeron for inferior detachments. Just to update you that the study has been accepted for publication. I received a PDF last night. And those of you interested, please let me know. I'll be very happy to share the publication of 134 cases. Okay, so let's talk about ILM pedicle graft. Just a show of hands, if a macular hole fails first time, how many of you decide not to do anything? It's a good sign. It means something is being done. Okay. Right. Well, this is not something very nice to see in your post-op Vitreo Retina clinic, where a patient is sitting in front of you with half of the eye full of gas and still an open hole glaring at you, and you would want to do something about it. Now, we did about 12 eyes of 11 patients. Age range quite diverse, mostly females. As we know, the incidence is nearly twice as much as females as males, and duration of up to 6 months. We know that the duration of macular hole surgery has bearing on macular hole closure, and one patient was over 5-year-old duration of the hole. One case was bilateral. Now, 11 of these cases had previous standard macular hole repair with 23 gauge vitrectomy, standard peeling macrorhexis around the fovea. I don't use a very large ILM rhexis, usually about 2 to 3 disc diameters in size, which is slightly decentered away from the peperomacular bundle. And then phase-time positioning, 7 to 10 days in all cases. This is my very standard procedure. I always take the lens out. One case was a failure. I'll talk to you about it in more detail shortly. So this was the first procedure. Now, the technique is pretty simple. If you look at this, sorry, how does this work? No, for the infrared. Okay, thank you. So you basically create like a crescentic, large ILM flap temporal to the previous rhexis. What's important is that it must leave a good hinge, otherwise it could tear into a free flap. Sorry, what's happening here? Yeah, okay. And then basically you lift this flap with your Eckhard's or ILM forceps, and flip it over so that it's sitting on, lying flat on your macula or macula hole. Now, as you know, when you peel the ILM, it tends to roll, and it's not easy to manipulate it. I don't use any viscoelastic. What I find is that if you use your Charles flute or while doing fluid air exchange, the water current will allow you to position your flap in the way you want. And this way you can iron out any creases, and it will nicely stretch over the hole. You normally don't have to stroke the flap itself, it's just the fluid air currents. And once it's there, the air will keep it in place, and then you use C2F6 or whatever tamponade you prefer to choose. Very briefly, how this now staining, as you normally do. Large flap is being created. This is the hard bit, because as we know, the ILM tends to be thinner the further you move away from the macula. And now this is the drainage cannula fluid air exchange taking place. You can see the flap is sitting on the macula. And last few drops of fluid coming out. I did not use any autologous serum or anything like that. This is a flap being created superiorly. If it fails in one direction, you can always attempt somewhere else. So what happened to the vision? Of the 12, 11 closed nicely. One patient who did not close was a primary case of a large macro hole of more than 5 years duration. One line improvement in 3 cases, 2 line improvement in 1 case, and 3 line improvement in 2 cases. In one patient, the vision was worse. So just a pie diagram of giving you an idea of visual acuity, less than 624, as opposed to majority of the patients gained between 660 and 624 acuity. Sorry, this was pre-op. Post-operative 624 to 69 was the vast majority. Few OCT pictures. This is the before the first operation, after the first failed operation. It's the final photo of the second procedure. Excuse me for the poor quality of these OCT images, but it gives you an idea of the anatomical closure. Further details on data if you're interested. So apart from one patient, after the first 11 patients worked, and I tried it in a patient with a chronic primary hole with atrophic margins, and it did not work. And I think in those patients, perhaps retinotomy, relaxing retinotomies would work. Thank you very much. In my view,
Any questions?
So, do we have a question from the audience?
So I may say something about your talk, Dr. Syed. It is great technique. I congratulate. This is really important that to make a message for the surgeons, because actually I don't like filling technique for recurrent case. What's filling technique? Amnion-membrane, retinal autograft, or the others. I call this is filling technique. But this one is like original ILM peeling, original technique, because you don't touch the retina, you peel the ILM and re-invert again in recurrent case. This is the grade. So what can we say? If the the original size of ILM peeling area, it's large, it's not possible to apply this technique. And therefore, maybe we can peel ILM, not a large area in the original surgery, like 2 disc diameter or at maximum 3 disc diameters. If we do this, if we have a failure case, we can apply this pedicle technique perfectly, and it really works like original surgery. Therefore, I really congratulate you. Thank you.
I agree with you, and I think introducing material into the hole, you have potential for damaging the RPE. Large primary rhexis is also to be avoided. We know that you get atrophy of the nerve fiber layer under the ILM. You might have seen that on OCT if you repeat it after 6 to 12 months. You get significant thinning of nerve fiber layer, and if that is on the papillomacular bundle, it will have a significant effect on vision. This technique is physiological. You're not putting anything through the hole. By the way, we've published, well, it's on its way to publication. You'll hopefully see it in paper one day. Thank you.
Thank you very much. So our next talk will be given by
Good afternoon. Thank you, Dr. Kakan, and all the committee for the invitation. We had very beautiful days here in Pakistan, and thanks for the kindly invitation and the hospitality and everything. Thank you all for your hospitality, and we are going to start to talk about amniotic membrane for large macular holes. So, amniotic membrane, you know that is not immunogenic tissue. We saw today many presentations of amniotic membrane in different pathologies like rheumatogenic retinal detachment and many other things. Now I'm going to talk my experience about 15 patients with large macular holes. So we are going to do the measure of visual acuity in logMAR. So we are going to see the results in logMAR. We did a retrospective study, mean follow-up 12 months, and we included all this data that you are seeing in the screen. So we did every month all the measures of the macular hole, and 15 patients were included in this study. This is one of the examples of the technique. You can do this technique in air, or you can do even in water, in liquid. So you have to be very careful when you put inside the eye the amniotic membrane, and to put under retina very carefully, because the amniotic membrane can slide, you can break the retina, you can have bleeding, so you have to be very carefully. And we, all the time, we use the OCT to be sure that we are on the site, on the correct size, on the correct site of the surgery. We check when we finish, and when we do the interchange, we check with the OCT again. So totally, we said 15 patients with average macular hole base, 1,200 microns, and we are going to see the results now. You can see most of the patients increase the visual acuity, talking about logMAR measure. You can see the increase in vision in most of the patients. We did the Wilcoxon test for statistical analysis at 3 months, 6 months, and 12 months after surgery. After 1 year follow-up, we have a statistical significance of talking about visual acuity in logMAR. Now we are publishing this article, and this, so we can say that we didn't have inflammatory complications or glaucoma complication, but we have one rheumatogenic retinal detachment secondary to the surgery. Macular holes greater than 1,900 microns didn't be better, and the patient who has better visual acuity when you do the surgery, where if the macular hole were less than 1,900 microns. Anatomical closure was observed 3 months in all the patients, And we need more studies, or we can perform a multi-center with both of you, a lot of you, if you want, multi-center, multi-country studies in the future. Thank you very much, and thank you for the invitation.
Any question or comment? Yeah.
Yes, please.
Thanks for your talk. Have you ever had to reoperate and see the behavior of amniotic membrane? Is it adherent to the retina? Is it stuck to the retina, or rather can
Can you repeat the answer, please?
you ever had to reoperate on these patients with amniotic membrane to see whether the behavior of the membrane is it adherent or stuck to the retina?
I didn't have a patient like that. Yeah. You? Have you?
No, it's an opaque barrier. Just wondered whether it might be worth taking the membrane out once the hole is closed.
Okay. Thank you.
So,
Do we have question, please? No.
As per your per-op OCTs, it looked like as if you were tucking it inside the hole margins, or were you just leaving it on the surface?
Yeah, we put inside under the retina, the borders inside the retina, and we check with the OCT after air fluid exchange. We check again. Yeah, we check
Actually-
2 times.
So the hole closed over it.
Yeah.
So that means
This is totally different technique. What you are talking overlay, and this is the plugging. This is the third technique. You go behind the retina, put it there, because all these putting it over the retina or under the retina acts like the same act. You just have to close the churning of the fluid from that hole. If you can stop it, whether putting it over it or under it, these holes will close like type 1 closure. If you will plug these holes, they will never close type 1. They will always type 2. And type 2, we all know, doesn't improve any vision. So even in the Danilo technique, they later on knew that whether when we are putting it under the retina, because it's not a transparent membrane, it's an opaque membrane, and they observed even that after few months, patient got the improvement of vision. Reason why? Because amniotic membrane gets thin with the passage of the time, and opaque membrane becomes more transparent with the passage of the time. So that's I do over, Riso do under, Danilo do under, someone is plugging, but I am not for that plugging one. Plugging one is nothing to do with the retina.
Dr. Manzur, I did few cases, and in those, the patient did have improvement in vision. But the next question is, it has been now 1 year now. The question is, should I remove that tissue, because it is sort of quite a large tissue over there. It's still lying there.
Thank you, Dr. Danilo.
But
Please
I know
take a
if
seat.
I remove it, I know that it's going to.
I will answer the question.
The hole is going to be open after that, it seems.
So, just a second, I'm sorry. Daniel, did you observe the resorption of amnion membrane during follow-up? So, when they resorb, and in all cases, the amnion membrane is the resorption that you observed, can you say something about that?
Yeah, all the cases, the macular hole resolved in all the cases.
But the amnion membrane is resorption, as is resorb in all cases? Or still remain there during?
Okay. Yeah, in all cases, we observed resorption on the amniotic membrane. Yeah.
Right.
So all our cases were type 1 closure.
Yeah.
Yeah, okay, good. Thank you, Dr. Danilo.
The resorption is
Thank you.
important for good visual recovery. Otherwise, when you put something under the retina, you will prevent the connection of photoreceptor. But amnion membrane has a big advantage that it resorbs by itself. Not like retinal transplant, not like ILM, not like lens capsule. Yeah. Therefore, this is the biggest advantage of amnion membrane that we can put under the retina.
Yeah.
So now I will request Professor Ramzi Evici from Turkey to present inverted ILM flap technique in macular hole surgery. What did it give us over conventional ILM peel? Dr. Ramzi Evici, please.
Thank you, dear colleague, dear Chairman. So these are my financial disclosure. I will summarize my experience with inverted flap technique during the last 10 years, almost. I applied this technique. So as you know, 360 ILM peeling is a standard procedure for ILM surgery. However, this technique is not good for a challenging case. And this group of patients that we call these challenging cases, and in this group of patients, standard technique has really very less anatomic and functional success rate. So during the last 20 years, several different techniques have been published to treat these challenge cases. And we summarize this in this list in 6 groups, but especially autologous thrombocyte concentrate, inverted ILM flap technique, and recently autologous retinal transplantation and amnion membrane graft became more popular. However, in all of this technique, but except inverted flap technique, we obtain very good anatomic success, but visual improvement is not really good. So recently, as Daniel mentioned, amnion membrane technique has some improvement about the visual function also, but inverted flap technique is, I think, is one of the good technique if you have a chance to do this to get good functional results. So first is published in 2010 by Michalescu et al. Then different technique like plug, we can solve this plug or insertion ILM into the macular hole. The classic one was multi-layer inverted, and very recently single layer inversion from different direction, temporal, inferior, superior have been published, but temporal flap technique became more widely accepted. So my technique is that I can show you with the video, and as I present, but the video is not running. It was running on the slide control room, but I didn't check here. Sorry. I checked all the video in the slide control room was okay, but here I think there's some problem because I have several videos. Maybe we can take the next speakers and we get ready.
Mohammad Tawfiq, are you ready? So we will take a little pause with the Ramzi's presentation. So Mohammad Tawfiq from Egypt will present his temporal flap for macular hole. Dr. Mohammad Tawfiq, please. Yes, Tawfiq, please start.
It's, thank you, Dr. Hussein, again, but it's better for my presentation to be presented after Dr. Ramzi, because we are collecting, completing the data that Dr. Ramzi said, but I will, you will keeping this away? Okay. I will just show not the benefit of temporal flap technique and the technique of temporal flap. I will show there's different situations that you will face when you decided to work with this technique. First, the first operation that I will show you, this is how to do it. It's a simple surgery. You just do a longitudinal cut and make your flap as large as you can, and you just go through the hole and don't cross the edge of the temporal hole. Don't cross the edge of the temporal hole. Lift the flap over the hole, and at that time you have two options. Go directly for fluid air exchange, put the fluid needle over the disc, or you can put a bubble of PFO to stabilize this flap until you complete fluid air exchange and searching, internal searching, peripheral vitreous shaving on air. So this bubble of PFO help you to stabilize the flap at a moment until you do a peripheral complete fluid air exchange. You have this option, or you have the option to do direct fluid air exchange and put the fluid needle over the disc to keep the flap floating over the hole and completing the fluid air. But this technique of bubble that I'm learning from Dr. Ramzi, by the way, he's helping you to make a temporal adhesion for the flap to stay there for a moment until you complete the fluid air exchange, as you can see. And you need to know the architectures of resolution of restoration of the outer retinal layer and how it's improving the vision. Also, if you have a chronic case like this with a larger macular hole, you can do this technique. Also, you don't need to manufacturing whether it's a small hole or medium-sized hole or larger hole. It can be done with a small hole with larger hole. You see how it's the beauty of architectures and restorations of the outer retinal layer. In this case, what's happening in this case? I do the regular ILM flap technique, but the snap is short and the flap is short, and I didn't do the bubble of PFC over the hole, and I feel that it's okay. I just do the flap and put it over the hole. You see the distance between the flap and the hole, it's short. Make it far away. You have a larger flap to cover the hole. So it's just a small flap, and I take it like this. That's okay. And this is what happened post-operatively. The hole is still open, and the flap is re-lifting again. What I'm doing in such a cases, you have two options. Either re-lifting this flap with the PFO bubble to stabilizing this flap, or to do what I'm doing. I just completed an envelope technique with multi-layer flap, because the patient and me not able to take another option to have a single flap. And that I'm learning from this case to have a larger flap, put a PFO bubble until you do fluid air exchange, to have a stabilizing flap at a moment until you finish your surgery. And this is what I'm doing. I completed it at the envelope multi-layered flap. In such a technique, you don't need to stuff the flap inside the hole. You just need to cover the hole with the flap. Don't stuff the flap inside the hole. Just keep it covered. But you see how the architectures and the restorations of outer retinal layer is totally different between such a technique and the single flap technique. Okay, it's by time it may be restored, but it will take a time, not larger than the flap. This is the case that we need to share with us, and we need to know your opinion. I go ahead for this case like that I'm doing in a regular ILM temporal flap technique. Take a small pinch and go far away a little bit from the hole. Make a single larger flap. Cover the hole with this flap. And after covering the hole with this flap, putting the PFO, finishing the case, and this is what's happening after removal of the air, and the air is disappearing. The hole is still open, but the flap is still there. Your decision in such a situation, even if you if you will do a redo for this case, like that I'm doing, completing the flap to envelope flap, or you will follow this case. Who will be following the case and who will redo the case? Raise hand if you will redo the case. 1, 2, 3, 4, 5, 6, 7. Redo the case. And who will follow the case? 1, 2. 2 will follow the case. My decision is just following the case, and this is what happened just 1 month after just following the case. What's the lesson that we're taking from such a situation? Is it a flap surgery or it is a relaxing surgery? You need to know this answer. The whole surgery, is it a flap surgery, or it is a scaffold surgery, or it is a relaxing surgery? You just peel the ILM to relaxing the hole. You need to know the answer, because it's not a flap surgery. We have like a scaffold over the hole, and maybe it takes the time to be closed. Believe me, also I need to share with you this situation. Not all hole need flap surgery, single flap surgery. I think just a peeling, 360 peeling may be enough. When you decide for the whole surgery to do a single flap or to do complete 360 flap, I know in UK every 90% of the surgeons is doing complete flap surgery. You remove the whole ILM flap, and it's going perfect, and the hole is closed. So you need to know, I don't know until now, where is the surgery to do single flap? Where is the surgery to do 360 flap? But for me, I need to keep the flap. Why we need to lose the flap? Keep it in the eye. We may need it any time. So just a single flap, it's okay. But also complete flap, it's okay. You can succeed to remove the complete flap. And now we will informed by Dr. Ramzi a lot of information about the Sembra flap. By the way, I learned this technique by Dr. Ramzi 2 to 3 years ago, and come here, Dr. Ramzi, to know about more about this technique. Thank you.
Okay, Dr. Tawfiq, just wait over there. So, very nice presentation. I will open the question regarding whether it's a relaxing technique, whether it's a covering or flap technique. Flap technique or cover technique, it's almost the same.
Yeah.
If I gave a comment, it's both, please.
It's both?
It's both. If you, as you shown the small temporal flap, it will work small temporal flap if there is a no tangential traction on nasal ILM, and that you cannot estimate before the surgery. You never know before the surgery. That I told you about the pit.
Yeah.
So that flap will only work in those cases where there is a no tangential traction on the nasal ILM and superior and inferior, and holes are not bigger one. That will work as a just flap technique. But if there is a tangential traction, then flap technique is failed. Then you have to get rid of that ILM also before putting that flap. One thing is clear, the size of flap doesn't matter. The larger the size of flap, more chances of dislodge. You just need to give a scaffold to the macular hole that will cover that macular hole. And so now you have to get rid of ILM in nasal, superior and inferior retina, then the temporal retina, if you want 100% success rate. I mean near to 100, not 100%.
But
sometimes you will be lazy.
You tried to put a scaffold without ILM peeling?
What I do, I peel the nasal ILM, superior and inferior.
No, without peeling. You tried first, at once you tried to put a scaffold, whatever is it, a scaffold,
okay,
without ILM peeling?
Yes, I do.
You do?
The similar flap size, I don't make bigger flap size. The similar flap size you showed, like 1 disc or 2 disc diameter, I do. But I have apprehension when these holes are more than 440 micron meter. Then I am 50-50. Maybe it will not. For 440 micron, many techniques work.
Yeah.
Whether you do even in
Just
this whole-
peeling, or just
even
this
this-
DVD. Just
even
this-
conventional will work.
Yeah.
We don't have a data that tells that in less than 440 whether conventional works more or temporal works more. Because nowadays temporal is more popular. You will see after 4 or 5 years, everybody will
Yeah.
forget it.
Yeah.
So techniques come and techniques go, but the basic principle is the same. You should have to remove the tangential traction first. Second, you should have a scaffold,
scaffold.
over the macular hole for larger macular holes, not
Yeah.
for the smaller 3 to 400. That's the main point. I think we should make it clear and sound clear. That's my point.
Yeah.
Yes, Manzar, please.
I think what's working in these cases is the removal of ILM temporal. Whether you put it on the hole or not probably doesn't matter. Because we know small holes you don't need to peel at all. 200, 300 micro holes. But big holes, even if you don't do a 360 macular access, as long as your peel is touching the hole, even if there's no flap, if you remove the ILM in any sector,
Okay.
in this case temporal sector,
So my question is, why we don't raise nasal flap?
it's
Big-
temporomacular bundle.
Yes.
Temporomacular bundle.
Why we don't take superior flap?
I'm sure it can be done.
What's the issue with the maculotemporal bundle? We peeled in conventional all ILM in maculopapillar bundle also. So the issue is not temporal or nasal. Issue is whether you are leaving all the tangential traction with the scaffold or not. If you are removing, papillomacular bundle doesn't come in this discussion because in conventional Iman peels, everyone peels the. If you go 10 years ago, everyone was peeling on the papillomacular bundle, and still in conventional we peel. So it's not about the papillomacular bundle, neither about the temporal. I bet you get a superior flap, nasal flap, it will also close. But temporal is more fancy nowadays. People use temporal flap. So I am still there that you have to get rid both pathologies. As in pit, you should get rid of 3 pathologies.
Yeah.
In one surgery, hit the 3. In one surgery, hit the 2. Don't wait for second surgery and grafting. So peel the ILM, put the temporal flap, I think would get the best result. Yes.
Would be worth doing 20 cases each of temporal, superior, inferior, and see the results.
Okay, agree. You can take the second one. This is lying second one.
You go. Can you go, Dr. Ramzi, and starting your presentation and give your comment?
Yes. Sorry for delay, Ramzi.
Sorry.
We really
Yeah.
apologize for this. Actually, that video format was not installed in this setup. I really apologize. So, Ramzi will continue his inverted ILM flap technique in macular hole. Ramzi, please.
So maybe I can tell something about the previous discussion before I start my talk. I think the issue might not be the release tangential traction, Hussein. Why? Because after inverted flap technique, this theory became questionable because we do not release tangential traction in inverted flap technique. The tangential traction is still there because the ILM is still there,
Yeah.
but the hole is closed. I think the issue is that to keep the whole area dry during a limited period of time, keep the whole area dry. You can keep it inverted flap, you can keep it autotransplant, amnion membrane. When we keep the dry and quiet that area, glial proliferation may manage to continue and fill this whole area. Otherwise, it's not works. This is my opinion recently.
Yes, I totally agree. As you remove the anteroposterior traction, so my idea is there's no harm to remove as much tangential traction you can remove during this procedure. And next, my question: why you don't take a nasal flap? Yes.
Little flap.
Yes.
So it's another aim of my features because I do not like to create a large flap, but it's not sometimes it's possible to do this in all case, and therefore we start with large flap and still we now getting smaller and smaller, and also from gas to air and minimize the surgery. So close the hole will be enough.
That's going to be the next project.
Okay. So you can continue with the video, I think, in my talk.
Elias,
So in this, some of the video is not working, but we will show like this. So this is my technique, standard technique. Keep an PFCL to close this area, very small bubble. This is my classic, in my hand, I call this as classic technique. And as Dr. Tawfiq showed, as again, this is PFO. This PFO bubble is very important to make a temporary stabilization of the flap. Also, to be able to, you can continue the talk, to be able to layer the flap as a single layers. So this is after surgery. You see, it hole is completely closed, and also the configuration is normal macular configuration. We call this U-shaped closure. Also, you can see recovery of ellipsoid zone external limiting membranes. Also, with the other eye of patient is almost same configuration, so same closing pattern that you observe. So we also compare this is the two technique. One is conventional ILM peeling and temporal inverted flap, and the cold closure rate was 100% in the, but in large macular holes, not standard holes, and was 70% in classic ILM peeling. Also, best characteristic visual value is better, but it's not significant, but better visual improvement in the inverted flap technique. We also evaluate closing types of macular hole. So in large macular hole with classic inverted flap technique, you know, we observe sometimes flat opens like this. We accepted this as, yes, it's successful surgery. But after inverted flap technique, we do not accept this as successful surgery. When we observe this kind of closing pattern in 360 ILM peeling. So in our cases, and we observe a U-shape or V-shape type 1 closure pattern in all eyes in inverted flap, but only when 1/3 of the patient in standard ILM peeling group was flat open closing patterns. So also complete restoration of ellipsoid zone external limiting membrane was better in inverted flap technique. So what we observe in these patients, also you observe that the notching in the surface of the retina in ILM peeling area, as you see here. We discussed this previously, but we touch with forceps and we make a mechanic damage, but it is not, because it is the, as you see here, the emphase OCT show perfectly flap and the ILM peeling area. You can see the dark spot. The dark spot is the same area that this notching. So we observed that this notching is dissociation of nerve fiber layers on the ILM peeling area. Also, we evaluate this the specialty of this dimples and all of the eyes. There is no single eyes that did not show any dimples in all of the eyes. Sooner or later, we observe this dissociations, and also the dissociations direction was the same direction of the nerve layers. Also, we can observe this in full thickness 360 ILM peeling area. But fortunately, there is no negative effect on functional results on these dissociations. So also, we observe the flap configuration and as a smooth single layer inverted flap or wrinkling, and another one is folding. You can see some fold on the flap or on the emphase OCT. Emphase OCT, you can maybe most of the surgeons do not use this one, but it's a really great technique to show vitreoretinal interface. We observe this wrinkling later after surgery because of proliferation at the edge of the flap. We observe proliferation at the edge, not over the flap. I don't know why, but I did not observe any proliferation over the flap. I think there is something, the inner surface, the retinal part of the surface of ILM, something is prevent proliferation over the ILM, but usually we observe at the edge. So in case of failed macular hole surgery, this test, this technique can help us to decide whether pedicle cleft can be done or not, whether ILM peeled or not. So, for example, this patient came to our office with failed surgery after the private surgery, and when we apply emphase OCT, we observed that the dimples and around the macular hole area, but there's no dimples here, so we assume that the ILM peeling area is this area.
And then we decide to create a pedicle flap from superior nasal quadrant where the ILM is closest to macular hole area. And therefore, I said in the previous discussion, if it would be a large area of ILM peeling, we would not do this inverted pedicle flap in these patients. So we can show the video again from the separate files. In this patient, we apply the staining of ILM flap, and you can see after staining, we observe exactly that we see on a phase OCT and peeling and unpeeling area of ILM. As you see, this is the ILM peeling area. This is the unpeeled ILM. So as Dr. Syed showed perfectly, we apply the same technique and at the pedicle flap or macular hole area. So it is the same original technique. So there is no damage, there is no things, an original part. And you can see the results of this patient. Look, again, the hole is 3 weeks after surgery is completely closed. And again, you can see the flap configuration here is perfectly layer or macular hole area. This is pre- and post-operative OCT angiography. You can see phase regulations. So even in a successful case, we can apply this inverted flap technique successfully like original surgery. So what about the operation and failed cases after inverted flap case? So we observe rarely this in my practice. For example, this patient has operated but very large macular hole and came to us with open macular hole after surgery again. So then we decide to do the second surgery. So we can go to the video. I think after this, the other videos is running. So when we stain the ILM, we observe that the ILM is returned to original place. As you see here, the ILM is again on the original place. So this surgery takes only 10 minutes to do this and remove the ILM in invert or macular hole area. I think you can continue with the talks. And this is after surgery of these patients. So this is preoperative pictures. This is 2 weeks after surgery. You can see the breach of ILM, as Dr. Tawfiq mentioned, and we wait this patient, and this also 12 weeks, 3 months after surgery is closed, and later on is completely filled this area, and you can see the functional recovery on the microperimetry also. This is the other patients that we applied surgery this patient. Please note that the date, and after you can see the date of this patient, we apply the same surgery. Again, this is fast video, but now in this patient we use large bubble of PFC, as I mentioned yesterday, to prevent staining of inner surface of the inverted flap and create temporal crescent shape and cover the macular hole area. So this is new technique that I'm using now, a large bubble of PFCL, not the small. I stain on the temporal area, not the whole area of the ILM flap. So normal standard surgery, but the patient come after surgery, week after surgery, you can see here, with the flap is floating in the vitreous cavity, and it's not open, not closed. And wait a week more, but nothing is changed, and decide to do operation again. And this is the second operation when we stain the ILM, and we observe that this line is showing the flap area in this area. And as you see, the flap is floating there, and re-invert again. And second time I gave air in this patient. I keep face down position. First 3 days I usually ask at least 12 hours a day, because the air tamponade is not so long period of time. But again, come a week after surgery, you can see the date, hole is closed, everything is okay, but 3 weeks after, so you can see the flap configuration and dimples over there, but 3 weeks after surgery came to patient with reopen again. This is the only case in my series that reopen after closings. So what did I for these patients? And I apply insertion technique and stain the ILM, and remove 360, peel 360, and insert ILM onto the macular hole area, because there is something that the adhesion process in this patient is not strong enough to keep flap over the macular area after closing. And therefore, I change this technique and apply these insertions on the macular hole area. And this is after surgery. Hole is closed, but you can see how irregular closing of the hole, the defect of the ellipsoid zone, because the insertion of ILM prevent perfect macular configuration. And therefore, single layer inversion is really important in this technique. So we can apply inverted flap technique in different challenge cases. For example, this diabetic patient, where severe diabetes, only one eye patient is type 1 diabetes. You can see some proliferation there. And also someone may say that there is a retinal proliferation why you apply inverted flap technique. So you can see it crescent staining and cover the macular hole area and complete the surgery with peeling membrane and lasers. And after surgery, again, gave a gas tamponade of this patient. And I think something I couldn't show the. Can we go to the back side of slide? So maybe last 10 seconds you can show. That's the video. Go forward. Yes, start from here. Yeah. Yeah, you can see the pre-op pictures, the traction, and the post-op pictures, and the patient has 20/60 vision with this eye. So inverted flap technique works perfectly in most of the patients. So also the other problem is we observe foveal displacement after ILM peeling surgery, and usually foveal displacement is towards the optic disc, and metamorphopsia after T-strict ILM peeling can happen after surgery, and usually foveal displacement increase parallel to the size of the area where ILM peeled, and the larger size and the more displacement. Also displacement is related with the metamorphopsia postoperatively. And we also evaluate in our patient with foveal displacement, and we observe that foveal displacement and metamorphopsia was significantly lower in temporal inverted flap technique comparing to conventional ILM peeling. And the less ILM peeling, the less foveal displacement and less metamorphopsia. So functionally, this is also another advantage of ILM peeling inverted flap techniques. So this is another complication that I have only in one case. This is before standard peeling technique again applied, but 5 days after surgery came the patient with closing macular hole. But as you see, the small bubble of PFO is remain under ILM flap. This is sub-ILM flap PFO. So the patient has 120/30 vision, but metamorphopsia. And see the flap here, there's only one edge of the flap is rolled over, but the other is perfectly closed. There is a macular hole area. And we decide to reopen this flap and reopen and remove the PFO. As you see, this is the adhesion was very weak. So when with the touching the forceps, it was easy to open the flap. So there is no strong adhesion, there is no strong proliferation ILM flap. Then keep again it open with PFO and use 4 to 1 gauge cannula to remove the PFO under ILM, and then re-invert the flap again. So after fluid air exchange, the hole is completely closed and vision improved 20/30. Then the last in 3 weeks is 20/25, and there is no metamorphopsia, and also you can see there is no RP alteration there. So in this eye, there was a almost 2 millimeters large macular hole. We follow this because the patient has already ILM peeling previously, but there was some 1 to 20 vision, but patient came with total tractional retinal detachment in our department, as you see here, as only one eye. And so ILM peel is already peeled in this patient, so there's only chance to do the peeling technique, it's amnion membrane or retinal graft in this patient, and because there is no other chance, and we apply detachment surgery, remove also prefer the retinal graft. As you see, I prefer very gentle diathermy, not very heavy diathermy, and remove the flap under PFO and bring it onto the macular hole area. As you see, the size of retina is same the size of a hole. I do not prefer to put retina under or over the hole and then apply silicone oil in this patient. So in this patient, and after surgery, this is first month after silicone oil removal, tamponade, and this is 6 months after silicone oil removal. As you see, is completely organized with the normal retina. Even it's not possible to size age of the flap. This is the composite pictures. The area of the retina is taken, and this is first month silicone oil tamponade under silicone oil. This is after silicone oil removal. You can see how the retina together organized together, and the vision improved to 0.60 in this patient. I think in retinal graft, we pay attention to not use a large retinal graft as amnion membrane because it's not resorbed by cells, and better to keep a same size with the original one. This is pre- and postoperative pictures. So single layer inversion technique provide more physiological and provide a more regular structure for glial proliferation, and as also reconstruction of retinal layers is clearly identified on post-op OCT as you see here. I think this technique help us to keep, as I told before, macular hole area dry and silence and away from the turbulence, and the glial proliferation improve the closing of macular hole area. So as I mentioned again, the classic theory that we should release the tangential traction to be able to close the macular hole theory became really questionable and may need to be revised, because in this technique we do not release any tangential traction, but we had a very good results. So in conclusion, inverted flap technique achieved improved anatomical and functional success results in large macular holes, and minimized the risk of iatrogenic trauma to the nasal part of the fovea and corresponding papillomacular bundle area, and minimized the risk of foveal displacement and morphopsia. And in case of failure, it provides another advantage by giving second chance to both surgeon and patient in the same condition, and it should be considered as the first option in the treatment of naive large macular hole, maybe in all macular hole. And in my practice, I use this technique in all macular hole because for the failed case, give another chance for me. Thank you for your attention.
So, Ramzi, great talk. We learned a lot. You introduced very interesting. So Tawfiq is there. So Tawfiq, the issue with the flap is not only the flap, whether it's covered or not. Ramzi showed how it covers, yes, whether it's wrinkled, whether it's little bit rolled. You showed the 3 types of flap that are over the hole. So it may be also the cause of those failed flaps. We see the failed flap only that has not covered it completely. But the wrinkling and other features of flap may play a role in what you think, Ramzi, yes?
But I could understand the question because here is not clear sound.
Okay, you showed us the types of flap, how they behave microscopically over the macular hole. Few were wrinkled,
Yeah.
yes, and few were smooth.
Yeah.
So, what do you think this smooth flap behaves well rather than wrinkled one? Yes?
So actually, I cannot say that functional results is better in smooth flap, Hussein, because we didn't compare this. But anatomically, I like to see the macular hole area is an original shape, original configuration. So we need more case to compare the results, functional results. We don't have enough case for this, but it can be. But another thing is that the retinal dimples, dissociation, this is very hard damage when we see the OCT, but the functional result is almost same. Also, we compare with microperimetric results. There is no difference between ILM peeling and not peeling case or inverted flap cases, and therefore, I don't know the answer of this question. It's affect the function.
Maybe with the future, with more cases, we may get few cases where maybe smooth flap, the holes behave well, and
Can be.
wrinkled flap in future didn't behave well according
So maybe this, the kind of wrinkling or folded flap configuration may affect also like metamorphopsia, like displacements and the other functions. So usually, yeah. Usually we ask the patient to read the letters and they read, but still they say something is different and it's not good quality. They have some complaining, so we don't know. The patient cannot explain, so we need more sensitive visual field tests to define this difference. Say. Thank you.
Thank you very much for this nice presentation. Just to remind myself and our colleague, there is many mechanisms that how we can close the macula. Putting a flap could work with many ways, either a bridge so the cell can grow nicely, or with decreased fluid, as you said, so the cells could be multiplated and closure it, or some of the theories in the past is that when you do vitrectomy is an insultation to the eye. It's a trauma. When you do eye limb peeling, it's a trauma to the eye. Any trauma associated with inflammation, any inflammation has some growth factor. All those increase the proliferation to be closed. Vitrectomy is you are removing the plug or the vitreous from the lacuna, which has started to happen inside the macular hole. So you remove the protruding with the vitreous in that area. All those theory together can give you a result of closure of the flap itself. Some of the theory even to go farther for those who do amniotic membrane or those who do a retinal graft and put it on the flap. It doesn't work only like a bridge. It doesn't work only like decreasing the fluid and promoting the cells to be proliferated, because the cells divide by itself, so it has to work side by side, neighbor by neighbor, till it's closed the flap. It's also provide a raw material for the retina to be healed. And this is why whatever we do in an atrophic retina, which has a flap, which has a macular hole, is never going to be closed.
Okay, I agree. Yeah, so there is multifactorial. There's only not one factor. I agree with you. Right. Yeah.
Thanks for sharing very elegant techniques. In my practice, if first two operations don't work, I give it a last shot with oil. If the patient agrees to have a third operation, I just wondered whether what you do if the second operation don't work. At what stage you give up?
You mean oil? So, actually, in flap with larger than 1000 micron, if it's very large, we need to a long duration of tamponade in this patient, actually, I believe, because it's not easy to fill all the macular area with gilial proliferation, and therefore, in such case, I prefer oil tamponade in a primary surgery.
Do you add it with other exudate maneuvers such as mobilizing the retina around the hole? There's some recent work being done on injecting saline under the hole to mobilize the blood.
It can be, but I did also that kind of mobilization surgery, but I found it's traumatized surgery, and I do not like that, and therefore, again, if in the primary surgery I apply only flap technique, then if it is unsuccessful, maybe we can do the other option was also mobilizing, but I do not like to do this in the first primary surgery.
Thank you. Sorry. Yes, tell me.
Last talk is Dr. Hussein Kakan, who is going to talk about amniotic membrane for refractory macular hole.
Thank you so much. Good afternoon, ladies and gentlemen. I will be very quick. I see a lot of sleepy faces after the lunch, so more busy, so I will try to make it some interesting rather than playing on the phones. So my talk is about the amniotic membrane graft. It's for refractory or secondary macular hole, not for primary macular hole. So it was about to invest the diagnosis and methods of all the patients. So I will not go all these data. We have already published this in Retina journal. We have the biggest data published till the date with the amniotic membrane graft in the Retina journal. So I will just show our technique. We have 33 cases till the day with AMG that have been published in July Retina Journal. So these are the, this is the preoperative fundus image, and the patient got about 1400 largest and 1000 smaller. This patient was operated by me. First surgery, she was 45 years old. She got a macular hole. I operated the ILM field as much larger. I feel that it's difficult to listen from there that time. So then she post-operatively, macular hole was not closed. She was advised to underwent a second surgery, but at that time I didn't know what I will do. So then as she listened for the second surgery, she just disappeared. After 6 or more months, she appeared again with the more loss of vision. So I was doing this technique with other patients. I planned the amniotic membrane graft. But I learned from this case a lot. This was my first learning, how the things behave. Means sometimes retrospective data gives you a lot of knowledge. So what I learned from this case and all my study, so where we get type 1 macular hole closure and where we get type 2 macular hole closure with the same technique. This is very important to learn. So this is the case. I am just injecting the again ILM if I get enough ILM. So I wouldn't go for AMG. It's from very beginning of my studies, maybe 2017. So I am just showing you the area that has not been stained with the ILM. So the issue was not with the ILM. The issue was not with the ILM. So it played some other factors that didn't let this hole closure. So plan was to do amniotic membrane graft. There's no rationale of having which side of AMD. Whichever the side is just provides the scaffold, and AMD has nothing to do. You can take other issues. So I do it under the air, and air has been injected, amniotic membrane graft piece, as you can see, you can take a little bit larger one. Some people say more. So my technique is I just dislodge this piece near the macular hole, not over the macular hole. With the soft tip extrusion needle, then I displace this graft over the macular hole. And I don't plug the macular hole, neither I put it under the retina. So I'm not of that school. Until the day we have the largest data for AMG outcomes. So that's my thing. I just put it a little bit, dip it like U shape. And all of my cases, those got the type 1 closure were the same technique. Those got type 2 closure were the same technique. No difference in 33 cases. When I was doing for data collection and publishing, I thought what I will tell them. So why they didn't close? So I again went to screen my data. What was happening with these patients? And although these patients were doing good, but not as good as I need, because the functional results were not good as compared to type 1 closure. In type 1 closure, I yesterday showed you the centrifugal movement of the layers, perfect. Amniotic membrane is lying over the closed hole. Here it is lying nicely. It looks beautiful. But it's not my objective. It was not my aim to get this one. For everyone, it's a closed hole, not the. So type 2, it's type 2. So where is the functional benefit? Is it okay? Yes, it is there. But how much? Not if you have a refractory macular hole, go for these grafting very early. Don't delay it. So, I mean, you can go for, I'm not a fan of retinal grafting. I never did and I don't like this technique. And if people did, they may be happy, I don't know. So these are the fusity. What happening with the time? You see the changes. People say graph stays same. No, people start working after 22. I'm working on this in 2016. I have 6 year data that tells me graph doesn't stay the same, believe me. Why you say it's opaque membrane? It is opaque, but it doesn't stay opaque. It doesn't contract, it contracts. We cannot remove it. No, we can remove. Even where I remove the membrane, where there was a icon closure, I just thought, really thought it was lying here, just wasting, just waste like a waste over there. So the only message that my talk has that early surgery for refractory macular hole, if you're going for AMG, we prefer for just scaffold technique, no plugging, no under the retina. So that's my message. If you have questions, so we can discuss it right now or whenever you want. So I just finished, so similar things are going on my next slide. Yes. No, I'm just answering the question that people used to ask me in meetings, that this is lying there, opaque membrane. What you do with this opaque membrane, I told in the morning session also, this become transparent. I have the follow-up 6 years where you cannot identify, you just identify the borders. You cannot identify because no vessel cannot grow in it. Neither CNVs cannot grow in it. As the patient that got CNV later on, his central patch is free of CNV, will you believe? They doesn't come through it. So I'm just answering that question. If it is lying there, you say, hole is closed, then why is it lying? Go ahead and move. It will not lie there. That's the answer. So, do we have any questions, please? Although my lyrics is gone. Yes, Daniel. So, do we have some? Mario is here. Mario is next.
But after this panel, after your talk, after Daniel's talk, I believe amnion membrane it's really can be a good alternatives in the other filling techniques. So really that was great experience, especially Daniel case series also is very good results. So I will try and I will use in my recurrence cases.
Because the main discussion, Ramzi, I tell you, the people tell me, whenever I'm presenting it from 2017, I was the first people were laughing on me on your meeting. So from where he came and why he is putting this graph, at that time you know the popular was retinal graph from Europeans and Americans and Tariq was doing, everyone was doing it. Oh, what the hell he is putting on the retina, why? And then next year a paper came, you know, in retina, and people said, oh, what a paper. 11 cases, 1 year, how come? So anyway, now you know the data is extending. Now people don't take it as an opaque membrane. Now people don't take it as an inert form. It as foreign body. If you think that it's a foreign body, remove it. Otherwise, wait for a few months. You don't need that patient being for 1 month or 6 months. You need maybe for 10 years or 20 years. So wait. Again, the lesson is patience. Retinal surgeon should be patient. Yes, please. It is natural, fresh from farms. I have a farm nearby my department.
Yeah, it's Mario Sarabia.
Just 50 meters away. I just
Yeah,
open the door.
from Argentina, but he,
It's fresh. We prepare
maybe he keeps us
because you know in Europe it's very expensive to store. Here we have the facility to store what buy. When you have fresh juice, no container juice.
Maybe he's fixing something.
No.
Yeah, man.
It is just a tissue that should cover that hole. Similar like an oral flap, similar like in what you just stop the churning of fluid. fluorescency and removal outcome. Where I removed now, I want to see how the hole, whether it comes back or whether it stays closed. So little bit patience and we will see different world in future. Yes. Thank you so much for having me. Any question? Yes. Walk little bit, it will be help in afternoon sleep. Everybody sleep, yes.
So how do you prepare your graft with this AMP? Yes, yes.
Nothing special. We just rinse it, clean it with the normal tap water.
You are in
Then
the-
I put it in antibiotics few times and then little bit.
Yeah.
You can take any one. I put it in gentamicin and I take electrolytes, I take cephalosporin and whatever the available. Yes, just 2 hours before, not just only before. You take and I keep it for 45 minutes. Then I rinse it with the iodine. After rinsing it with the iodine, again clean it. Then I put it again in the antibiotic, 2 steps. And from there antibiotic it goes on my steroid trolley. From that steroid trolley it is again washed and then it goes on my final trolley. So 3rd step. So 3 steps in cleaning.
Ramsey,
No, whatever size. How you don't confuse this technique with the size. It's just a gap and you put it on the head. Just
Let me
put it
write.
in the hole, that's all. Don't confuse the thing. When everyone is asking about size, it doesn't matter. Yes, please. Yes, that has been all the graft that have been taken, but only on the elective cesarean sections. And patients' consent were taken, ethical approval were taken. Otherwise, retina is 4.6 impact factor. They are not going to publish me. They are not even going to listen. I followed all the Helsinki ethical committee. Give me the approval for all these things. How retina that can
thanks a
publish?
lot, yeah.
Yes, under there. With wires.
Yeah. Next year.
Under there, it's difficult.
Amsterdam.
That's
Amsterdam.
You know why? Why? It's a sticky membrane. When it's air, it doesn't dislodge from the floor cell. That's also a trick. Under air, it doesn't dislodge. Daniel knows when it's under air, it doesn't dislodge. It's very sticky, like gum.
Yeah.
It's difficult sometimes to dislodge it. But
Yeah.
under air, it's well controlled. So any question, Ramzi can add and Daniel can answer.
We can continue the next.
Dr.
We're
Fakar,
finished.
do you place it and
No.
Okay.
Okay, we're finished.
Yes.
can it be placed under a bubble of PFO? This AMP?
Why if you want to paste your PFs? If it goes
I will-
under
I would like to go there for the exhibition.
Under air? You put it under air?
we are done. Ramzi and Daniel will conclude the session.
Yeah. We
Daniel. You can do it.
maybe we learn these days many techniques, different results, and maybe the issue is we can perform every technique, and in the future we are going to see more different results of these techniques in different countries. So we can work together because now the internet, we can work at the distance and make trials, prospective multi-center trials in our countries and still having networking. So thank you for everything. Thank you, Dr. Khan, for the invitation, and thank you for being here. Thank you very much.